Hello, my name is Sarah Shabasi. I am a current PGY2 internal medicine resident at Franciscan Health in Olympia Fields. My poster today entitled Testing for Blastomycosis and Histoplasmosis Prior to Initiation of Biological Therapy is a project I've been working on with Dr. Awad and Dr. Rich in the rheumatology department at my hospital. Before we get started, I'd like to review what encompasses a good screening test. Good screening test has been defined as a test that fulfills the following requirements. It should be able to identify a significant health problem. There needs to be available treatment and an early phase of the condition so that the treatment can be given. The screening test should be available to the population and cost should be considered as well. With this in mind, my poster today will be focusing on a urine antigen screening test for histoplasmosis and blastomycosis prior to the initiation of biological therapy. Prior to this current study, the study that inspired this work was a 2011 investigation by Mayo Clinic in Minnesota, which was retrospective in nature, entitled Histoplasmosis Infection in Patients with Rheumatoid Arthritis. Patients between the years of 1998 to 2009 who had a history of rheumatoid arthritis and concurrent infection of histoplasmosis were identified. These patients were receiving corticosteroid therapy, DMARD therapy, including methotrexate, and anti-tumor necrosis factor therapy, either one of these or some combination of the ones stated. They were able to identify 26 patients with verified diagnoses. 15 of the 26 required hospitalization, and 5 of the 15 required ICU level care. Most commonly, these patients were presenting with pulmonary involvement. This involvement ranged anywhere between a dry cough to disseminated infection. If we look at image 2 in the poster, the disseminated histoplasmosis is identified on this cross-section CT. You can see the effects that histoplasmosis can have on the lungs. Current guidelines for therapy, for initiating TNF-alpha therapy, states that we should be testing for TB, viral hepatitis, and HIV. No current guidelines for fungal infections, but there was another study that was conducted that looked at patients that had been started on TNF-alpha therapy and went on to develop fungal infections. They were treated for their fungal infections, but and they got better from there, but they did go on to develop symptoms from something called immune reconstitution inflammatory syndrome, which can be simplified to an explosion of the Th1 response when a TNF-alpha agent is suddenly stopped. So in that way, it can be seen that starting someone on TNF-alpha therapy may be harmful without screening for fungal infections, especially in highly endemic areas such as ours. We can look at the map here in image 1 and can see that southern Illinois and the upper portion of Indiana actually overlaps for the occurrence of histoplasmosis and blastomycosis infections. The next figure talks about the data from WHO obtained in 2015 of the infectious burden globally. And although histoplasmosis and blastomycosis is not the most common infection, if it were to manifest, the mortality is significant when it's associated with it. The hypothesis for our study is there's a higher incidence of asymptomatic fungal infections in rheumatological patients than previously documented. These patients will benefit from screening and subsequent treatment of indolent infections prior to initiation of biologic therapy. For our experiment, inclusion criteria will include all patients with rheumatological diseases such as RA, sarcoid, and SLE who are being started on biologic therapy for the first time. We will exclude anyone who's been on it previously. Using this data, we will determine the actual incidence of endemic fungal infection in our patient population, and we are hoping to contribute to future guidelines that can be looked at prior to initiating biologic therapy. This is a clinical trial that can be further classified as a screening trial, and like I said before, we'll be using a urine antigen test, so it should be cost effective as well, but we are currently working on that. We are hoping to have at least a sample size of 100, and we will statistically analyze the data once we are able to be at that point. At this time, I would like to thank the Rheumatology Department Internal Medicine Residency at my hospital, and I would like to thank ACP for the opportunity to present this research. Thank you.